right, thank you very much, everybody, for being here. I think this is a really, really exciting time for healthcare. I feel like we're right on the precipice of really hitting the tipping point and seeing a lot of the great advances that have been made in the field start to get deployed, start to see the real impact of the work that we've been doing over, for some of us, the past several decades. So before we get started, two things. One, I would like to get as much audience participation as possible. Hitting the questions that you guys are interested in, I think is going to be very important. And then the other one is I want to do a quick poll of the audience and see what is kind of the demographics taking place. So first, how many people here would describe themselves as a data scientist? All right. How many people are actually healthcare providers? More than I was anticipating. How many people are students? Nobody.
It's too expensive.
Do we have any healthcare executives present? A handful. How many people are on the health insurance side? All right, and then the last one I'm going to ask is, how many people have actual experience deploying an AI solution within an institution? Well, I'm pleasantly surprised. All right, so with that quick poll, I want to let our panelists give themselves a brief 30, 60-second introduction. Let us know who they are, what their focus is, and why they're excited about AI in healthcare. Can we start with Yin?
Sure. So my name is Yin. I'm an assistant professor at NYU Langone Health. I'm also a director of clinical predictive analytics. I run a machine learning shop. I have a team of data scientists and engineers, and our job is to focus exclusively on how to translate models from the literature and ones that we build our own into actual clinical practice at the point of care.
Paul?
Great. My name's Paul Bleicher. I'm the CEO of OptumLabs. I'm a physician scientist who's been a serial entrepreneur in the pharmaceutical and healthcare industry for a number of years. For the last 6 years, I've been building OptumLabs, which is a collaboration partnership amongst 30 or so healthcare stakeholders who work with Optum's data. And Optum is the healthcare services and technology organization that is roughly half of United Health Group, which is the largest healthcare organization in the United States, if not the world. And we are also an innovative group, OptumLabs, that has been building artificial intelligence, predictive models, and other machine learning solutions that have been adopted and have been put into production in the United Optum enterprise. And
Katherine?
Hi, I'm Katherine Chrysalis. I'm an assistant professor at the University of Toronto and at Harvard School of Public Health. I actually live between the two countries and go back and forth. I would call myself a health research methodologist. I do clinical trials. I have clinical trials that are going on in both Canada and the United States, including the Boston area. I'm more of a researcher. I'm on the research side of things, even though I teach executive leadership, healthcare leadership. But I ask clinical questions, and mostly in the space of cardiology and gastrointestinal diseases.
All right, so Yin, I would like to start with you. I know you guys have an excellent pipeline put together in order to facilitate the actual deployment of a lot of the algorithms your team works on. Can you describe to us what a successful AI in healthcare deployment actually looks like? And can you tell us what's the biggest contributor to having a successful deployment?
Sure. So ultimately, the success of an AI algorithm is really driven by sort of the outcomes, right, that you want to capture. And the success is also driven by these huge multidisciplinary teams, right, that come together. And earlier in the previous talk, there was some reference about, the analytics folks reporting the CEO or the CIO and other high-level chiefs. And I think that's 100% true, because the only reason we can get things done in our organization is because we have leadership from the top that's bringing together a lot of different people, right, to make these things happen. So I think in terms of success, right, on the data science side, there's sort of three elements that you need for success. One is access to the data. And so that can be very hard. A lot of healthcare institutions are quite fragmented in their IT infrastructures, and they're not all unified. At NYU, we're all an Epic shop. So everything we get is 100% standard. And we don't really have to worry about trying to unify different databases from one another. The second criteria for success is high performance computing, right? Having a cluster, having some of the compute available, right? So that you can develop the deep learning models, the other models that you need to build. And the third is expertise. So our group is actually an academic operational hybrid. So we work closely with the Center for Data Science downtown at NYU Courant. We also have deep learning faculty on my staff, as well as at the university as a whole. And we have a slew of students that are constantly looking for projects and things to work on. And so we take those three things together, and on the data science side, right, that's sort of our elements of success. Now, you also have to think about what happens on the Epic integration and the workflow integration side. So on the Epic integration side, we have a whole team who manages, figuring out what exactly is going to happen when these models fire, right? When they predict that something is going to happen, right? How is that going to be built into the system, and how is it going to be surfaced to the front-facing physicians? And finally, for every project, we have a clinical or business sponsor that tends to be the chief, either the COO, the CMOs, or the CMIOs, and their job is to figure out the workflow, is to figure out exactly what's going to happen, what type of full-time employees or other resources will be required to make that thing happen, and to deliver on that. And then finally, at the very end, we have a sort of evaluation team, and this is sort of a classic biostatistics statistician who, at the very beginning, thinks about, okay, what do we need to do? How long do we need to run? How often does this thing need to fire? And what do we need to do to show that this thing is actually delivering value? And when we define value, we define it in terms of cost. It can be in terms of quality of care. It can also be in terms of sort of savings of FTEs, right? Or increased compliance more efficiently. And so we have a lot of different measures of sort of success, and we essentially report on all of them. And then our stakeholders kind of, mew in their own minds about whether, that's a success or not.
So, Paul, I know AI in healthcare isn't necessarily just clinical. On the administrative, logistical side, there's also, a large amount of potential improvement within the institution. Can you talk a little bit about that side?
Sure. Well, to begin with, just to get a picture of who Optum is, Optum actually serves the payer community, the provider community, and the life science community, and consumers as well. So we have a very large and complex business in which there is a tremendous amount, because healthcare has this, there's a tremendous opportunity to improve inefficiency, to improve quality, and to reduce costs. And so as we think about AI models, I want to begin by saying that we've been doing artificial intelligence, which we call OptumIQ, if you will, which is part of our OptumIQ, for a very long time. Back from in expert systems and typical logistical models and predictive models. This is just a part of the DNA of what any organization that is working with administrative data does. But what's gotten a lot of excitement, I think, today is not only the compute and the new algorithms, but the ability to intervene on the basis, or to predict on the basis of text, and text in a historical context, in a linear context, if you will, as well as images. And our focus is really on text. So we have a tremendous amount of text data. We have a lot of decisions that have been made in the organization. For example, for prior authorization or for a decision to send someone to a skilled nursing facility or elsewhere, or whether something is an overnight observational admission or or an inpatient admission or fraud, waste, and abuse. There are a lot of places where administrative information has been used for a long time by experts, by physicians and nurses and experts, including coding, to make decisions. And those decisions are recorded. So that gives us the data that's necessary, the labeled data, to be able to create an augmented intelligence that works along with the experts, if you will, to take care of a bulk part of the decision making, but not all of it, and to refer those things that need to be referred. But what is, I think, most important in thinking about this is that a lot of, I think, AI that's being applied today are people who are very clever and have great ideas about what they can predict, but haven't thought ahead yet about what they're going to do with that information. And so this is a little bit of what you were saying as well, which is we start with what is the problem? Where is there a need for doing something? And what will we do with that information? How will we use it? Will it be cost efficient? Will it save somebody from having a serious or fatal outcome? And then once we've defined all of that, what data are necessary to be able to address that problem? And finally, that's when you apply the AI algorithm. And it might be complex, it might be deep learning, because it might involve text, but often it can be simpler than that and doesn't require, and you have to think about implementation, you have to think about keeping those things in production, because we're not just thinking about experimental models, we're thinking about things that go into production and are used on a day-to-day basis in a multi-billion-dollar organization. And then what, sustainability, if you will, of the solution.
Excellent, excellent. I do want to come back to workflows in a second because I think those are critically important. But first, Katherine, I wanted to ask you, on both the clinical and the administrative side, the regulatory hurdles can be really debilitating when deploying in a healthcare environment. As somebody with international experience getting those regulations on both the Canadian and the American side, can you speak to those hurdles and what has to be done in order to overcome those?
Oh, geez, that was an easy one. Well, there's a lot of hurdles, and I feel like the whole AI field is just evolving so quickly that medicine and regulatory hurdles, policies have not been able to catch up. They're not really aligned at this moment in time. And when we think about the backdrop of medicine's mantra is do no harm. And it's really important to understand this. It's very different than other industries. It's kind of unique that way. So there's a lot of hesitancy to embed AI into different areas within healthcare. And I'd like to say that, even though we have, it's a mine of a question, but there's so many layers. There's data privacy, there's HIPAA requirements, there's different regulatory bodies in Canada, there's GDPR in Europe that's monitoring a lot of this or dictating how to proceed in next steps. This is like a very, very new landscape that's really not well laid out. So there's some hurdles in starting to implement your stuff. I'm in hospitals. It's actually really difficult to embed things that involve patients immediately on the floor in direct care right now. More of the stuff is in the workflow area or in classification problems and, using MRIs or CTs or whatever to better predict disease incidence. But the actual hurdles for the patient is really, really, really a problem right now because we just don't have the same policies or the developed policies to be able to navigate that field quite seamlessly.
All right. Once again, I want to invite anybody with their own questions. Please make your way up to the microphone. That way you can get feedback from our panel. But I do want to come back in the meantime to workflow. You know, one of the things that's just never taken into account in our field is workflow, especially when you think about the academic institutions who might be a little more insular and not as directly exposed to the hospital environment. It's really hard to really appreciate just how critical it is to get actually be able to plug into that workflow seamlessly because, 2 additional clicks and you've lost the clinician. And so I'd like really perspectives from all of you about how do you ensure that you're taking into account the workflow? How do you make sure that you can integrate it seamlessly? And then how do you get buy-in from the clinical team to make sure that they're willing to help you optimize that workflow and make it contribute to the care practice? Yin, can we start with you?
Sure. So almost every clinician that works with us is ridiculously excited to work with us. They already have a tacit buy-in into what we're doing. And our goal as the unit that I run is to convey information to them in a way that they can feel confident that what the model is producing is indeed true. And so we kind of do that in 3 ways. One is through data. So anyone that's familiar with clinical trials, right, and drug design understand that medications are somewhat like black boxes, right? And so, we identify a cohort of people, we give them we randomize them, we give them the drug, and then we look at the outcomes, right? And that's really the way that we treat our models as well. Some of these models can be very sophisticated, they can be very hard to explain, and they can also have explanations that make no sense at face value, but if you actually look at the causal chain of events, right, to the actual feature, there is a relationship. And so rather than getting into all those details with our clinicians, we essentially show them that, look, when this model is run, I want to predict readmissions, and it works. And these are the outcomes that you can expect when this model is running. So, based on that background in sort of pharmaceuticals, right, they have this framework to understand these outputs and really sort of take them and say, okay, yeah, I believe you. I believe that this is what it's doing. So that's one. The 2 is experience. So as we're producing these models, we actually send the examples of the patients that are identified to the physicians. And the physicians can see those patients and say, oh yeah, this patient definitely looks like someone who's really sick. This patient definitely looks like someone that, is at risk of being readmitted. And through that experience, they're able to connect their cognitive understanding of what these models do to the outputs that the model actually produces. And it gives them confidence that these models are indeed doing what they're supposed to do. And the 3rd thing we do is infrastructure. So for every model that we build, we have a pretty vast amount of monitoring tools that allow us to monitor the systems at all times. So sometimes we have upgrades that will, sort of wipe out variables that the model actually depends on, and we can catch those beforehand and actually shut those models down until we repair them and bring them back up. We also have tools in place to monitor sort of the positive predictive values and the other values that we're trying to gather. And so through that process as well, we're able to see whether the models start to drift, where they start to learn things that, or start to head in directions that are no longer classifying the patients that are being identified. And through those 3 processes, we're able to give our providers and give our leadership confidence that, we have the situation in hand and we know that we know what we're doing.
Paul?
So, I want to approach something other than trust. Well, first of all, I think one of the things that a large institution, as opposed to a single institution, has to worry about is overfitting. And I think that's a very significant problem because we're developing solutions that need to be applied to across the board, across the U.S. healthcare system, which is and I think there is a risk when you're using individual institution data to have something that works well for one institution. And also, medicine changes over time, and so you need to actually make sure that you're constantly updating your models and testing your models so that they're accurate. So that was to address that. But to your workflow question, since 1997, since my first startup, Phase Forward, the problem has always been the same, whether it's about prediction or about software adoption. And the Gartner Group figured it out, and they copyrighted it, but I'm going to borrow it, which is people, process, and technology. So you can have the best technology, you can have the best algorithms in the world that are incredibly accurate. but you have to understand what the process this is going into and how it's going to be used, and then you have to bring the people along who are going to be able to use it. Because if you create a process or a technology that doesn't work for those people, you're not going to actually get a successful implementation. So often it starts with the people and understanding what their process is. It's important not to be married to the process that they have been using on paper or otherwise, but it is essential that that you don't think of this as the rollout of a technology. We have a gigantic group that does the in-production rollout of the technology. We use a team of teams of a number of different groups that puts things together, et cetera. But in the end, the most important thing is making sure people are trained, they're brought on board with it, that it's something that fits with their existing process and that's going to get used. Because any great technology that's deployed out there that doesn't get used is going to fail.
It's interesting that you should mention process. I actually teach quality improvement at the Harvard School of Public Health for executive leadership. And one of the things that we focus on is understanding the process. When we do different tests, when we roll out a new process of some sort, we test it. And just like they do in classical engineering, we use our different statistical tests to see if it's actually working. Did we create a change, and is it in the direction that we hope that it would go in? And it's actually it starts in steps. There's a lot of steps. There's a lot of buy-in that you have to have from the clinical teams. There's a lot of reluctancy. I mean, I implemented my first clinical trial at Brigham when they were rolling out Epic. And it was really challenging to have people training how to use Epic and then starting to put a clinical trial at the same time. So there's a lot of real life glitches that I think sound idealistic on paper, but when you actually are in the hospital and trying to implement these, you have to have some experts from the inside to help you navigate behavior change, which is a huge piece that is probably grossly underestimated. Mm-hmm. And you need to have it. You have to have patience more than anything in how to roll it all out.
I think we have a question from the audience.
Yes, there's a question related to what you're talking about with the models and patient care and giving data to clinicians. I wanted to see how far along we are in that, because I think it's all about patient care and then giving the right information or good information to physicians to make good decisions, this kind of thing. And I'm thinking of cases where, and I have some personal experience in my family, like a senior, 10, 12 drugs, has been in the hospital 9 times over the last 20 years, and being able to look at that quickly against data that comes from clinical trials, comes from real life data, how far along are we and where do you see this going? So we get good information to the physician, good patient care.
And I'm actually going to expand on that question a little bit to the point where especially in healthcare, maybe even beyond other industries, so much of the time, the why is more important than the what. And so being able to explain to both the clinician, why was this prediction made, and then enabling the clinician to explain to the patient why they think there's this diagnosis or this treatment is going to be successful. How do you go about making sure that you're providing the why to the clinician as well as the what?
So the why is a challenge with some of the newer artificial intelligence methodologies, and people are working on it. People like Regina Barcelay at MIT and others. And we actually have made some inroads at being able to highlight charts and indicate what the key things are that are driving a decision. But it also is important not to, so we created a predictive model a number of years ago back at Humedica where we were predicting patients who were going to be hospitalized for congestive heart failure. And the clinicians wanted to know what the and it was a logistic regression actually, because machine learning didn't perform any better. And the clinicians wanted to know what the coefficients were. They wanted to know the why. But in fact, as long as you demonstrated that it was accurate, the why was not only unimportant, but it actually was potentially deleterious because a model was predicting factors that that could be measured that predicted that a patient was going to do poorly. That didn't mean that those were causal. And you know, correlation does not mean causality, and it was essential for the clinician in the process that we developed to bring the patient in and examine them and make the decision for them on their own what was wrong with them, rather than trying to treat their high BNP or their you know, whatever parameter was driving a particular decision. So you have to be a little careful with that. I'm afraid that I just answered that and didn't get to the other question.
I think we have another question. I'd like to get to as many as possible in the limited time we have, so.
Okay. My name is Yelena Naumova from Tufts University. I'm very intrigued by the comments related to the ethics of using the new technologies in healthcare. And I'm curious about how you see a structuring conversation on the harmful effect of those destructive technologies in the long term, because it's very easy to create a panic about vaccinations, about any changes you will do. So how you see that conversation can be developed and evolved in different layers in our audience of being constructive? Well,
the ethics. It is a problem, and I think this is where the hesitancy is in developing the policy right now. When we think about, we have data privacy, there's so many layers to this all. There's so many opportunities for things to go wrong. And so it's a complicated question, actually. But I feel like there's the whole mantra of medicine, the context of everything in medicine in the background is do no harm. And so when you have that and something goes wrong, then ethically who's going to take responsibility for it? Then there's the other thing in the clinical trial world, from the world of randomized controlled trials, we have the concept of statistical significance versus clinical significance. Great, we found this effect and it seems to be statistically significant, but what does this clinically mean and how am I going to change my practice? Will I change my practice? And is it really ethical for me to treat 200 patients with this one drug to have the change in one person? So the numbers needed to treat. There's a lot of complexity to this, and we really haven't navigated this field yet. It's, for any ethicists that are out there looking for work, this is a good opportunity.
Just one comment. That's the reason that we focused on administrative uses of this, because errors in patient care can be harmful. In administrative care, they can be inefficient. They can cause frustration in having to reapply for, questioning a decision or whatever. But in general, it's not at the same level of risk as actually making patient care decisions on the basis of artificial intelligence.
And this kind of goes back to the what. If it's clinically significant, then the physician will have the buy-in to act on the what. If it's not, then you're not going to get their buy-in.
And our approach, for every one of our projects, we actually have sort of an ethics and privacy, I guess what we call consult, right? Where we look at each prediction task, right? And there's someone that sort of looks at it and says, and at least takes a moment and steps back and thinks, okay, what are the consequences, right? What are the potential consequences of this action, right? So that's one. The second thing is through the IRB, right? So we have IRBs in place, and that's their job, right? Is to look at the things that we're trying to do and try to put bounds, right, around what is reasonable and what's not reasonable. The third thing that we do is at the point of clinical care for some of the things that may have more ethical sort of considerations, we have a process where these type of questions, right? Say your model predicts something and that something is questionable, right? Or maybe should or shouldn't be done. We have a process to kick that up to a higher ethical committee, right? That actually makes a group decision as to what is the proper, level of care for that patient, right? And so in no way, in no part of this, right, are we prescriptive, right? We never let the algorithm just do something and then prescribe a treatment without any intervention. There's always a human in the loop, right, making decisions. And that process of having the humans in the loop, right, is the same process process that, allows these electronic health record vendors to work without FDA approval, right? Because the human is always in the loop. And so we sort of take the same mantra, like, look, we're just providing a piece of information for you, right? At the end of the day, you're the provider and you're acting on the information, whatever it may be. And that's how we sort of, avoid getting into the sort of prescriptive phase of things.
Although, as someone who's been involved in regulatory from the pharmaceutical industry, et cetera, that argument may work within an individual institution, but does not necessarily work for a company that's developing a product. And there are things that cross the criteria of having to be registered as devices by the FDA.
Right. And if we ever expanded outside our institution, then, we would have to take a hard look at the FDA requirements, right, that are required around some of these tools. But as long as we're within our institution, right, we're just trying to solve the problems locally before trying to solve them globally, because we know how hard it is to translate these things into actual clinical practice.
So unfortunately, we're out of time. 30 minutes is not enough time to do this topic justice. That being said, I would like to invite everybody to the AI in healthcare sessions that'll take place both this afternoon and tomorrow afternoon. Please come there if you're interested in the topic, and please join me in thanking our panelists.